Coronary artery disease is the most common kind of heart disease and the leading cause of death in the United States for both men and women. But there are promising new efforts to screen and diagnose, including using computed tomography or CT scans to visualize and spot coronary diseases before symptoms develop. Join us today as we learn more about rapidly developing techniques available through Catholic Health Services of Long Island. On today's episode of CHS Presents Lifestyles at the Heart of Health. Hello, everyone, and thanks so much for joining us. I'm Jane Hansen. Left undetected or untreated, coronary artery disease can lead to complications and even death. Joining me now to discuss more about this preventable disease is Dr. Lev Libarsky, Director of Cardiac Imaging at St. Charles Hospital, St. Joseph Hospital, and St. Catherine of Siena Medical Center. Welcome. It's good to have you here.
Thank you.
So let's just explain for everybody exactly what is coronary artery disease.
The gradual accumulation of plaque, which is mostly composed out of cholesterol and other inflammatory cells in the vessels that supply blood flow to the heart muscle, gradually narrows the lifeline to the muscle and limits the blood flow. Left undetected, as you properly mentioned, it leads to what we refer to as a heart attack. And luckily, modern science gives us ability to prevent the problem, recognize it early, and save lives.
I think you have a picture to show us of how it actually looks or what it consists of. But so the difference is that it's the disease that leads to the heart attack.
Correct. So wonderful thing about my field is it can be detected early and it can be intervened early by a combination of lifestyle changes as well as pharmacological or other sort of intervention. So things don't necessarily happen suddenly. It's a gradual spectrum, gradual progression. And if we refer to the image shown, the plaque, as I described, accumulates very gradually. And the technology that we bring into the Catholic Health Services, called CT or CT angiography, is one of that absolutely unique tools that can recognize the disease way before a heart attack actually takes place. So as the graph shows, the plaque begins to accumulate within the walls of the vessel and only with time begins to actually impinge on the inside of the vessel, limiting the flow.
Is anybody at risk for having this happen?
So conventional risk factors, as we know, such as genetics, family history, which sadly we cannot change, and other things that we are kind of responsible for, whether it's fast food or tobacco or cholesterol levels, which are not necessarily genetic, but the consequences of your lifestyle. Those things absolutely contribute to this, and with proper changes, we can improve things.
We've been talking about heart attacks and coronary artery disease as a killer for a very long time. Are we doing a better job at taking care of ourselves?
Yes, we are. So one of the reasons why the average lifespan of women and men in America, and actually in most of the industrial countries, improved is driven by improvements in cardiovascular wellness. So people literally live decades longer as they were in last century.
I know that a lot of people say to me, I've had a stress test, I'm great, no problem, don't need anything else. But isn't it true that sometimes stress tests do not pick up problems?
Excellent question. Yes. So one of the newer things that we bring into the population presently is ability to recognize the disease before it's being appreciated by a stress test. So the concept of coronary calcium scoring, which we will discuss shortly, or coronary CTA, is ability to see the blockage earlier in the spectrum of the disease that we can see in this outline and intervene before people even have symptoms. So for example, just simple fact that most heart attacks happen in people with smaller blockages, which cannot be detected by a stress test.
You mean just like a teeny tiny little blockage
Absolutely.
versus something really big that's going to
Correct.
capture
So
attention?
one thing that patients ask me in clinical practice is, do I have a blockage that just flies out and gives me a heart attack? Well, that's a little bit of misconception because most of the heart attacks happen, and I give analogy of a volcano. So if you have a silent volcano and then you have an eruption, that's the concept of a heart attack. So you have exposure of that cholesterol inside of the plaque that might be just a 40% blockage to the blood flow, and then you have a blood clot formation. And then that blood clot is really what seals off the vessel and limits the blood flow. So most heart attacks happen in people that cannot necessarily be detected by a stress test. So for example, this image shows that the blockage within the walls, that bright spot on the screen, that's an actual heart vessel, that's not a cartoon, can rupture and cause a complete blockage of the blood flow.
Is this a normal heart, or what am I looking at here? Because I don't know.
Right, so this is probably one of the nicest images we have, and that's an example of a true CAT scan, this technology we're talking about, reflecting a heart with normal vessels with no evidence of blockage. It's a three-dimensional reconstruction, where this is an example of an early plaque that we described. It's a thin gray line that you can see with an arrow. And this is more pronounced examples of those blockages, which are bright white on the screen. None of them can actually be detected by a stress test because they're not necessarily blocking blood flow at present time. A patient such as this should be controlled by statins, which are medications which decrease the cholesterol, they decrease the inflammation of the vessels, make it less likely for that volcano analogy to take place, and aspirin is frequently prescribed.
What does aspirin do?
So aspirin is an analogy of wearing a seatbelt in a way
Really?
that when you put a seatbelt, it doesn't prevent a it doesn't prevent a car accident. However, in case of a car accident, a seatbelt may save your life. So in aspirin, it doesn't prevent a heart attack. If there is a rupture of a plaque, it makes a real heart attack less likely to happen. Whereas a statin, which are commonly prescribed medications for reduction of cholesterol, a statin can actually prevent a heart attack in a way like proper driving courses do in terms of prevention of a car accident. So those are the analogy I usually give.
And people take statins so that they reduce cholesterol or eliminate cholesterol. How do you know when you're supposed to do one of those? Again, you've taken one of these tests and it looks like the plaque is building up.
So one test that I truly want to mention is called Coronary Calcium Score. It's a test that actually St. Francis proudly, almost I would say, pioneered in a few decades ago. The point is that calcium scoring is not done to address a particular complaint. A calcium scoring is done just like a mammogram, for example. It's a pure screening. It's a pure prevention. So if you want to be proactive about your personal risk assessment of a heart attack, calcium scoring is the way to go.
So you could ask your doctor for this test?
Absolutely.
That sounds like an excellent idea. Well, I know we're going to talk next about the CT cardio screening ability. And you're going to come back at the end of the show, and we're going to have much more to talk about.
Thank you very much.
We'll be right back. We're going to take a quick break. Have more right after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. Cardiovascular computed tomography, or cardiac CT, is the most advanced non-invasive tool enabling patients to be safely imaged to diagnose or rule out coronary artery disease in a timely way. Joining me now is Dr. Salvatore Trezzera, Associate Chief of Cardiology and Cardiovascular CT at St. Joseph Hospital, who's been instrumental in leading this program at the hospital. Welcome. It's good to have you here.
Thank you, Jane. It's nice to see you again.
You must consider this to be just the greatest tool.
Absolutely. It's something that we conceived of probably several years ago to bring cardiac CT and cutting-edge technology to St. Joseph and other hospitals within the CHS system. Cardiac CT really is what we consider the most advanced non-invasive tool in detecting coronary artery disease at an early juncture in time. Years potentially before it could potentially cause a heart attack.
Years?
Potentially, yes.
Wow. So when you first brought this into the system, is this considered, revolutionary compared to what's available at a lot of other health centers?
Well, cardiac CT has evolved, as Lev, my colleague, said, back 20 to 25 or more years ago, initially from electron beam CT, which studies were done at St. Francis. Over time, both cardiac calcium scoring and then coronary CT angiography, which is done now today, has come to the point where it is definitely the most advanced technology. It is not a technology that you will see generally at community hospitals. It is a technology that has evolved through tertiary care centers and large institutions because it is an expensive scanner to have. We've come to the point where our images are so sensitive that we're able to detect coronary disease in vessels that are millimeters in thickness. So we're real happy to have this ability.
I was making fun of the word slice, but the reality is what you're literally doing is they're like slices of pictures through almost tissue by tissue, correct?
Correct. Well, we use the terminology slice, and in fact, it's the number of detectors, X-ray detectors that are on the scanner. And if you think of making pictures on a television with pixels, think of it in such that it's the more pixels, the smaller the pixels, the higher the resolution of the image. To bring it to layperson's terms and how to understand this. A great deal of data in a very short period of time is collected, goes through a computer algorithm, which then puts together both two-dimensional and three-dimensional images, enables us to look at the coronary arteries and the anatomy really in multiple levels, in almost like a virtual surgeon would.
Wow. Okay, so who should have this? This is not a test you just give to everyone who walks in the door.
No, the question always becomes who shouldn't in our American society. With our diets being what they are, with our obesity and hypercholesterolemia, high blood pressure, tobacco use, and all these traditional risk factors that Lev talked about earlier, when a patient comes into our office in the outpatient setting, if they have chest pain, atypical types of chest pain, which they think they might be having heart problems, along with multiple risk factors, this would be an opportunity potentially to do calcium scoring and coronary CT angiography to detect disease early. That's one instance, which is an elective circumstance. The second instance, which is in the circumstance of patients coming into the emergency department with acute chest pain syndromes. Generally, traditionally, we've done cardiac enzymes, multiple cardiac EKGs, observation on a telemetry unit, and traditionally days in the hospital, possibly stress testing, and subsequently angiography, which can cost us quite a bit of money and time and
anxiety
and resources, correct, and resources to the hospital. Our newest program, which is contiguous to the emergency department in several of our CHS hospitals, enables us to get a patient with chest pain, do one normal EKG, one set of cardiac enzymes, risk stratify the patient, make sure that they have no contrast allergies, make sure the appropriate size, and have the risk factors, and then they can be scanned. Once that patient is scanned, generally within hours of them having that chest pain event, we can read the scan and we can triage that patient. A normal study can go home. A mildly abnormal study can follow up with their physician or be referred to cardiology for then prevention, further prevention from progression of disease. And in the event that the patient does have a significant blockage in an artery, they could subsequently quickly be sent on to coronary angiography right that day. So in effect, we're saving time, we're saving money, and obviously we're saving lives, and we're getting these patients in and out of the hospital quickly and back to to their families.
So why shouldn't it just be part of a regular physical exam once a year or once every other year, especially if you have high risk factors?
Well, it's always an economic issue, and it also is the lag of insurance companies understanding the benefit and the cost effectiveness of a test like this. Rather than needing EKG, echo, and stress test, and maybe nuclear stress test and time, this is a test that potentially in the future, calcium scoring and or cardiac CT angiography should be used much more liberally. The other issue is you have to train physicians to understand and know about this. This is not something that certainly most primary care physicians know about. And again, once the insurance companies catch up and recognize that this is the most cost-effective test and the best at detecting disease early, and population studies are done with this type of testing, you will see that this should evolve in the future to be the test. That being said, Dr. Lebarsky and myself and other physicians who are that do use this technology, we integrate this into our armamentarium of tools that we know when to use it and when it's appropriate and when not to use it when it's not appropriate.
Boy, I wish insurance companies were listening right now. We're going to take a break. We'll be right back, have some final thoughts about today's discussion. Stay with us. Welcome back to CHS Presents Lifestyles at the Heart of Health. As we wrap up our shows today, some final thoughts with our guests, Drs. Trezera and Lebarsky. So I want to be sure people know where they can go to get the kinds of testing and everything that we're talking about today. Talk about the programs at the individual hospitals.
We have cardiac CT at several CHS hospitals. I primarily am at St. Joseph Hospital. Lev and I work together at St. Joe's, and we have St. Catherine's, we have St. Charles, St. Francis,
right,
the DeMattis Center, and also Good Samaritan Hospital.
So there's a lot of places to go. It's not just one individual. And this CT, the cardiac CT scanning, is available at almost all of these facilities and at the ERs as well?
Correct. So the technology can be utilized in different type of patients. In the emergency room, it's utilized in people with active chest discomfort. This technology facilitates quicker discharge, more precise diagnosis. But also, as Dr. Trezera mentioned, it can be used in outpatient setting. It can be utilized across the country, essentially, to better understand patients' risk, to implement medications on personal risk stratification.
As cardiologists, it must be really rewarding to know that you can take tests like this, state-of-the-art technology, and be able to use it to not only tell people if they've got how high a risk they might have, but also to relieve that anxiety that they don't have heart disease.
Yes.
What's that feel like when you're able to deliver that kind of news?
Well, I say that oftentimes to patients that I think that a normal test is as important as knowing that there's an abnormal test, because oftentimes patients have had chest pain which may be related to anxiety and possibly even things like gastroesophageal reflux for years. And they continue to go back to the doctor with chest pain. And they've had multiple stress tests which are normal. And yet in the back of their mind, they're still concerned that there might be heart disease. Well, in this case, we can say to them, look, you have perfectly normal coronary arteries. There's no calcium even in the arterial wall, thus that your risk is so infinitesimally small that you can basically worry about something else.
Go worry about the bills or something. And of course, when there is that buildup, that plaque buildup, it takes years and years to accumulate.
It's very powerful knowledge to actually downgrade someone's assumed risk. by having a coronary calcium of 0, or if you had chest pain and CTA showed no blockage of any sort. So to tell a 50-year-old individual you don't have to take daily aspirin, or if your cholesterol goals could be a little bit looser than originally planned, it's a wonderful news.
Do you ever use them on younger people? I mean, people who wouldn't have a long history of plaque having a chance to build up and that sort of thing.
Specifically, calcium score is not ideal for people younger than 40, 45, because most of the database, most of the matched population starts in the 40s and not sooner. However, this technology is wonderful for congenital heart disease. So if someone is born with anomalous vessels in the heart, or as a matter of fact, chest, this technology is outstanding. It's actually called gold standard. Nothing beats that for understanding of congenital disease.
And you've even had patients that you've been able to use this for.
Absolutely. We've had patients where we have had incidental findings of coronary anomalies. Lev has shown me some of his cases from his database. And we also can use this to define the anatomy in congenital cases, perhaps that have been operated on before. And in some cases, we've even had cases that the information is useful for a surgeon who may be operating on a young person that may have an aneurysm or a bicuspid aortic valve. So it has a great deal of utility. The beauty of cardiac CT too is this same scanner that's in the emergency department, from a cost-effective standpoint, is excellent because it also does body, head, chest, abdomen. So when a hospital invests like we have in this type of technology, not only are they getting the cardiac CT aspect of it, they're also able to use this CT scanner all day long on all the other ER patients. So it's not just a machine that is purely dedicated to cardiac. It's cardiac integrated, which is important to hospitals.
I'm just curious, we keep talking about coronary artery disease as being the biggest killer in this country. And I jokingly asked you earlier about, are we making inroads? But are we making inroads? Are people doing enough to prevent it on their own before they get heart pain, before they have to come and see you guys?
We can always do better. So absolutely. So these movements about healthier diet, more exercise, the counties investing into bike lanes, I mean, all of that honestly fits into your idea. Absolutely. We should be doing more.
Additionally, really to plug a future program of ours, which is related to this, is we have an evolving discipline called sports and exercise cardiology, which focuses really on prevention and exercise, both in people who just like to exercise, who want to be fit, or masters athletes who in fact have heart disease or may be at risk of heart disease, who we can integrate into utilization of this type of technology and potentially prevention and management of masters athletes who want to run into their 70s and 80s, who want to play basketball or tennis and things like that. So the answer to your question is yes, we do have to do better as a population.
But the technology is really assisting us as we go forward, because if you get a clean bill of health, for example, you're probably more willing to do those things. And even if you don't, you can fix it now, and which means we can go forward and then continue to do preventative stuff.
Yes.
Last words to our audience about what they should do for their hearts?
That's the tough question. It's all about self-discipline. It's about reaching out for help. If you feel that you fit into that higher risk, whether it's genetics or habits, go to a doctor, be intelligent, thanks for your program, ask proper questions, and we're here to help.
You're here to help.
Absolutely. Everyone has a heart, so Lev and I would all agree everyone needs a cardiologist.
On that note, I'm going to say thank you very much for being with us today. We truly appreciate it. And as always, for more information or to schedule an appointment with Catholic Health Services, simply call 1-855-CHS-4500 or visit chsli.org. Thanks so much for joining us today. I'm Jane Hansen, wishing you goodbye and good health.